Hi, everybody. I'm going to talk to you today about stress testing and imaging as part of this resident lecture series. So those of you who have been on the wards know there's a lot of different cardiac imaging technologies that are out there. This is not meant to be a comprehensive, you're going to know how to read these studies. This is more just kind of to let you guys know what the studies look like, what you can expect from the studies, what indications are for different types of studies that we have available. Or I guess this is pretty much what I told you, what the indications are for testing and which patients we send for different types of tests. First starting with coronary artery disease or coronary heart disease. So when we talk about coronary artery disease, we're talking about atherosclerosis or plaque buildup that can lead to thickening and hardening on the inside walls of the arteries. And so this buildup of plaque can narrow the arteries and lead to angina symptoms, which usually is like chest pain or shortness of breath. If it completely blocks the arteries, then the patients usually present with a heart attack. If there are blood clots that form inside, but they intermittently block the arteries, they can just present with an acute coronary syndrome. And so that coronary artery disease probably represents the most common type of heart disease, second to, I guess, hypertension, if you consider hypertension to be a heart disease, but the most common type of heart disease that we see in developed countries. And so our testing evaluation for patients to assess for coronary artery disease, it's important to know, usually we do non-invasive testing. And amongst all the different types of tests that are available, the sensitivity and specificity usually falls around 85%. And what that means is that any of the results you get, whether positive or negative, 15% of these results are going to be false. They're not going to be true. So given these limitations, the recommendations are that we don't actually do testing if there's a low or high pretest probability of coronary artery disease. What does that mean? So by Bayes' theorem, depending on, as I mentioned, test positivity or negativity, we kind of refer to this as the likelihood ratio for test positivity. So if the likelihood ratio is 5, and let's just say our pretest probability, the likelihood we think this patient's going to have coronary disease, let's say it's a 22-year-old woman who's coming in with chest pain, no cardiac risk factors, we see that even if she has a positive test, the post-test likelihood that she has coronary disease is only 10%. So it doesn't really change it that much. Whereas if we take somebody who has pretest probability of about 40% and they have a positive test with a likelihood ratio of 5, then it significantly jumps us up into closer to 80% for the likelihood that they're going to have a test. So tests actually changed a lot in terms of what we thought about this patient. Let's say the likelihood, just to give an example, let's say we take a high risk, somebody who we likely think has a disease, pretest probability of 95%, and then their test is negative. We can see that this really only drops their post-test probability to about 70%. So really not that helpful because they still have a high likelihood they have underlying disease. And again, if that intermediate probability, 40%, and they have a negative test, it drops their post-test probability to about 5%. So positive aspect on how we think about this patient. So stress testing. When do we do stress testing? There are 3 main reasons we do.
Dr. Srichai?
Yep.
Just really sorry to interrupt, but I'm not sure why the slides are transmitting in a very blurry way.
Oh, you know what? Let me change it. I think because I changed it to optimize for video.
Oh, yeah. That might be.
So I can shape. Maybe
if you unshare and then reshare. Usually they'll optimize for video.
Yeah,
okay.
usually it kind of works.
You just try to reshare and it should work.
Let me take you mean reshare, or I'm going to take off the optimize for video?
Okay, sure. And then if you have a video, then
you'll let me know if it doesn't look good.
Yeah, look, it now looks
Yeah, now
very
it's great.
sharp, although this is the,
If we just flip the displays, then you're good.
Oh, whoops.
where it says display settings at the top.
Top left.
Perfect.
Yeah, it looks good. You're right.
Oh,
Thank you so much.
okay. All right. All right. So when do we think about doing stress testing? For detection of obstructive coronary disease, and that's important, obstructive coronary disease, meaning patients who we think have blockages in their arteries of at least 50% or more. For risk stratification, and if we think a patient may have an underlying arrhythmia that's reflected by exercise. I have to it's flipped now for me. So in general, we don't test patients for stress testing unless they're actually symptomatic, or we feel like, and they have an intermediate pretest probability for having underlying coronary disease, as I mentioned, because of the likelihood ratio and where the usefulness of diagnostic testing runs. In general, asymptomatic patients, the guidelines recommend that we don't screen asymptomatic patients, although there are certain cohorts where it may be important. For example, patients who have a lot of risk factors and who are in high-risk occupations who have the potential to cause harm to other people. So, for example, airline pilots, where it might be important to know that this person may have underlying coronary artery disease that could affect them when they're flying a plane with a lot of people on it. Okay. So with symptomatic patients, there is some guidance in terms of how likely are they to have underlying coronary disease based on their symptoms. When we think about angina, and angina just refers to symptoms that are common to having underlying coronary artery disease, typical angina symptoms are such that are described often as substernal chest pain or discomfort, usually triggered by physical or emotional stress, and then relieved by rest or sublingual nitroglycerin. If they have 2 or 3 of those characteristics, we label it as typical angina. If they only have 1 of the 3 characteristics, we label it as atypical angina. And if they don't have any of these characteristics, it's considered to be likely non-cardiac chest pain. Why is this important? In this study that looked at patients and prospectively followed them for almost 6 years, they showed that patients who had typical angina had, as well as some atypical angina, had higher mortality rates compared to those whose angina symptoms were considered to be non-cardiac. What's important to note is that typical angina presentation and the literature that accompanies it refers to patients and during a time when most commonly coronary artery disease were in men. And so typicality is more common, or we say that's typical, but typical for men. Women, elderly, and diabetics often have what we call atypical presentations, or rather atypical for men. So these patients may present with symptoms at rest. They may present more with shortness of breath symptoms when they're exerting themselves as compared to actual chest discomfort symptoms. May have GI symptoms or unexplained fatigue, localized pain, or pleuritic pain. So in certain patient groups, it's important to understand that they may not necessarily be typical. And what about the patient who says they don't have any symptoms at all? So history is very important because oftentimes what we've noticed is that patients will adjust their activities. And so they'll say they don't have any symptoms, but you have to ask them a little bit closely, like, what are they actually doing? Are they doing the same things that they were doing a year ago? They may have adjusted their activities because they were having symptoms and they just don't realize, and they think that their symptoms are just a result of getting older. So it is important, this asymptomatic patient, to really question, are they really asymptomatic, or are they, have they just adjusted their lifestyle such that they are no longer having symptoms? the modified Diamond and Forrester criteria is used to kind of using clinical guidance to estimate a pretest probability of underlying coronary disease. And they use kind of the algorithm looking at the age, gender, and then the typicality of the patient's symptoms. And so typical symptoms in a male who's older generally has a high pretest probability of underlying coronary disease. And whereas patients who have what's considered to be non-cardiac chest pain in a younger patient group have low pretest probability of coronary disease. And so you can use this modified Diamond and Forrester criteria to sort of assess, well, what are we talking about with this patient, and will cardiac testing help me in this setting? There are risk tools that are out there that allow you, or that are on the internet, that allow you to just plug in a patient's data, and it'll give you a clinical model as to what their pretest probability is. I think this was the Erasmus one. And there's other ones out there. I think there's a Duke one that's out there as well. So you can also do the risk model that's out there and just plugging in parameters. Other patients that may be referred for stress testing, patients who have had a heart attack, and we're really using it for prognosis, as well as for prescribing activity and rehab assessments so that they can get back to their normal lifestyle. And then also patients before and after revascularization, either to determine if a patient has multivessel disease, which vessel is actually the one that's causing the patient's symptoms. If patients already undergone revascularization and they're having chest pain, to assess whether the chest pain is related to something with regards to their procedure or not. Finally, if a patient does have multivessel disease, looking to see how many territories are at risk. Is this something that is fixable with just PCI of a vessel here or there, or is this someone that would benefit better from surgery? Other kind of aspects to understand with stress testing, women in general are thought to have a lower sensitivity, although similar specificity as men in regards to results from stress testing. And then elderly patients and arrhythmia evaluations, also consideration. Again, it depends upon why you're getting the test. Is it for diagnosis? Is it for prognosis? Or is it for evaluation of arrhythmias? And who do we not stress test? So absolute contraindications, important to note, and these get screened all the time before a patient is put on a treadmill or undergoing a pharmacologic stress. So patients who are having an acute MI, they have unstable angina symptoms or uncontrolled arrhythmias. Those who have symptomatic severe aortic stenosis, and I highlight the symptomatic part because we will stress patients with aortic stenosis, but not if they're symptomatic from their aortic stenosis. Acute PE, acute aortic dissection, or symptomatic heart failure, these are also patient groups that do not benefit from stress testing and stress testing can cause harm in these patient populations. And then another question we get asked is, how frequently should a patient undergo stress testing? If a patient has underlying known heart disease, known coronary artery disease, I think in the practice in the past had been, oh, I got my screening stress test and I'm fine. We actually don't recommend stress testing them every year as they used to do in the past, only really if there's a change in their symptom pattern. And mainly it's just because therapies now suggest that medical therapy is actually just as good, if not better, than revascularization procedures, and that really revascularization only helps the patients who are symptomatic. All right, so what kind of modalities are there for evaluating a patient, both with stress testing as well, just in general for coronary artery disease? So a lot of different modalities out there. First off, not all stress tests are equal. As we can see here, exercise ECG stress testing, which is a plain treadmill without imaging, has the lowest sensitivity, although similar specificity to some of the other techniques out there, but it is the cheapest, and so is often the first line recommended stress test in patients undergoing evaluation. Other considerations, whether to do imaging versus non-imaging. So a plain treadmill versus the addition of imaging, and this becomes very important because as I mentioned, the addition of imaging adds a lot of cost to the stress tests, and so a lot of insurance payers are recommending non-imaging stress tests unless there is a contraindication or it's going to be non-diagnostic. And so these are, if they demonstrate these findings on EKG or they're undergoing treatment with digoxin, those are patients who might benefit from the addition of imaging to a plain treadmill. Other indications, so if a patient's already undergone a non-imaging exercise stress test and it was equivocal, then imaging general, they can be repeated with imaging. And then, as I mentioned, other ECG findings such as left bundle branch block, if they already have ST depressions at baseline on their EKG or really significant abnormal repolarization abnormalities, then imaging is important. And then if it's performed mainly to look at if the patient already has known coronary disease and you're trying to get more information about the extent and which vessels are involved, then then you're going to want to do that with imaging. And then finally, the type of imaging modality that you use, and I mentioned there's several out there, and we'll go over some of them in just a bit, but that's also an important consideration in determining which type of test you're going to do. So what does the patient look like? Which type of test is going to give me the most diagnostic information? Do they have contraindications to certain types of stress testing modalities? If I'm undergoing a pharmacologic stress test, and the patient has COPD or significant arrhythmias, it therefore is going to affect my choice of whether I'm going to do a dobutamine stress test versus a regadenoson stress test. What is best at your institution? Not all institutions have all types of stress tests available, so depending upon where you are, it's important to know what the local expertise is there at your institution. And do you want to get other information out of that stress test? If you want information on valvular structure, hemodynamics, ejection fraction, then you might want to do it with an imaging modality that can give you that additional information. If you are interested in what the patient's exercise capacity is, then you don't want to do a pharmacologic test. And so this is just kind of like a flow chart showing, depending upon what type of information you want to get from the test, and then going down into kind of decision making in terms of whether to do an exercise versus pharmacologic and whether to do imaging or not. All right, I've kind of thrown around different terms here. So when we talk about stress testing, we talk about different types of stress. Physiologic versus pharmacologic. And when we talk about physiologic stress, we're talking about basically exercising the patient. Most of the times when patients present in the office, they tell you that they're having symptoms. Often, as I mentioned, typicality for angina is often with exertion. So you want to mimic that exertion to see, is this patient, are these symptoms really cardiac related or not? In general, we usually will recommend a physiologic type of stress tests in all patients who can exercise. And traditionally here in the US, we do treadmill, but and for some reason in Europe, they tend to do bicycle. We do have the capability of both here at Georgetown to do treadmill or bicycle. So those patients who aren't really able to walk on a treadmill, but can do fine on a bike, and you really want to do an exercise stress test, just remember you can order it as such, as a bicycle stress test. For those patients who really can't exercise, pharmacologic stress testing is available. And we sort of divide this into two groups. Inotropic, where we're looking at the squeeze of, mainly an agent that's going to affect the squeeze of the heart. So dobutamine is the common agent that we use here. Or a vasodilator stress, which is commonly used in our perfusion studies and looks at coronary flow reserve. Dipyridamole and adenosine are older vasodilator agents that were used, and more commonly now we will use regadenoson, which is a adenosine receptor analog. As I mentioned, physiologic stress is what best mimics a patient's metabolic state, and we will always try to advocate for physiologic stress testing whenever a patient can exercise. Inotropic agents are thought to mimic the physiologic stress, and so if you want something that's going to be most similar to exercise, then using an inotropic agent is the best choice. As I mentioned, vasodilator agents, we call them stress tests, but technically they don't really stress the heart. They just preferentially dilate the vessels, and in normal vessels, they dilate more so than abnormal vessels. From a patient standpoint, we call them all stress tests, but from the physiologic standpoint, I like to consider inotropic agents more as a true type of physiologic stress, and vasodilator agents, even though they are giving us information in terms of stress testing, they really aren't stressing the heart per se. All right, with exercise ECG stress test. So this is just the plain exercise stress test where we're only obtaining the EKG at baseline and then with exercise, and we're also getting other parameters in terms of exercise parameters, what the heart rate is doing, what the rhythm is doing, the EKG and blood pressure and breathing are monitored. And diagnosis of coronary artery disease, again, obstructive coronary artery disease, is based primarily on looking for ischemic ECG changes. And what do I mean by that? So again, there are limitations. So if a patient has a baseline ECG that already shows a lot of repolarization abnormalities, this is not a patient that should only get a plain ECG treadmill stress test. But looking for things like, but if they have a good baseline EKG, then looking at what happens to the EKG, and particularly the ST segments during stress, is important for identifying whether a patient may have underlying ischemia. If there's no change in that ST segment, then it's considered to be a negative stress test. Upsloping ST depressions, as can be seen here on the second image, and oftentimes when they're exercising, we might see a quick upslope or a slow upslope. Generally, if it's more than 1 millimeter, we'll call it positive, but it's generally considered equivocal when it's upsloping. We really want to see this horizontal or downsloping ST depression of at least 1 millimeter and at least 2 consecutive leads to call it a positive stress test. Generally, when we see ST depressions, it usually doesn't localize where the where an underlying lesion is. It just kind of is indicative of ischemia is present. And the lateral leads V4, V5, V6 are the most sensitive for detecting ST depressions suggestive of ischemia. In general, if there's greater ST depression or there are more leads involved, that usually signifies there's more extensive myocardial ischemia. ST elevation, it can be seen, but it's usually uncommon, and oftentimes when we do see it, it's usually in pre-existing leads that have Q waves already and doesn't usually suggest ischemia. However, in a patient who has a normal resting ECG, then it can be indicative of transmural ischemia. And either when we do see this, it's usually suggestive of either vasospastic angina, so coronary spasm, or that the patient may have severe multivessel coronary disease. Also, AVR, it's kind of an unusual lead because it kind of goes in the opposite direction of the other leads. ST elevation in this lead is actually a strong predictor of either left main or proximal LAD disease. Other abnormalities that can be seen with stress, so ectopy, particularly when there's ventricular arrhythmias, that's associated with increased mortality risk. And then development of bundle branch block, that could suggest underlying coronary disease risk, but it also may suggest just underlying conduction system disease. The other reason that we like to do exercise stress testing is because of the wealth of prognostic information that's obtained with the about the information. So information on how far they can go, what their heart rate does during stress, how quickly it recovers post-stress, whether, as I mentioned, they have arrhythmias or not, what the blood pressure does. Those are all all have important prognostic implications. And we tie in information about the ECG response as well as their exercise capacity in one prognostic score called the Duke Treadmill score, which you may see on some of the reports if you order a stress test. Okay, moving on to stress testing with imaging. So nuclear imaging, SPECT and PET scan. So the addition of nuclear imaging, the addition of imaging in general helps not only to identify ischemia, but to also localize where the ischemia is. It can also give us information about whether there is also infarction present, as well as whether scar tissue is representative of, wall motion abnormality may be representative of scar tissue versus whether there could be underlying viability present. In addition, nuclear imaging has been around for a long time, and there's a lot of other prognostic information that can be obtained from the imaging study itself, beyond that obtained with the exercise indices. We use the appropriate use criteria for guiding us in terms of when it's appropriate to consider doing cardiac radionuclide imaging. I'm not going to go through that, but there's a whole host of indications, but most commonly it's when the patient is symptomatic. And this is for diagnosis of underlying coronary disease. In these guidelines, they also talk about risk assessment and the importance, again, with the prognostic information and data available with nuclear imaging, that it should be shown to be good also for prognostic assessment. And so for those of you who are unfamiliar with nuclear scanning, this is a SPECT scan where with nuclear, we're looking at perfusion. So a tracer is injected and we're looking at uptake of the tracer into the myocardium. And there should be uniform uptake within the myocardium. The traditional way we lay out nuclear scans is short axis images in the top 2 rows, long axis images in the bottom, 4 rows. If there is uniform uptake, then you'll see that the images show homogeneous uptake of the tracer throughout. Generally, stress images are displayed on top of the corresponding rest images, and we can quickly go through and we can see that it looks very similar on the top row as compared to the bottom row. This is a bullseye that basically takes the heart and squishes it from apex in the middle down to the base, and again, just kind of synthesizes the information that we see on this splash layout into one image. And again, should look similar on rest as well as stressed images to suggest that this is a normal negative nuclear scan. In a patient that does have underlying ischemia, however, we expect to see changes at exercise or during stress compared to rest. And so as I mentioned, the stress images are by convention laid on top of the rest images. And whereas in the prior example, there was nice homogeneous uptake of the tracer on the rest images, here we can see that although the rest images look pretty homogeneous with maybe a little bit of a defect here at the apical inferior segment, on the stress images, we see there's a larger defect out here, which corresponds to the anterior lateral walls, which we see on the stress images. It looks normal actually in those areas. And on the bullseye chart here, we can see there's decreased tracer uptake corresponding to those segments in the anterolateral wall. And this is suggestive of ischemia in the left anterior descending and circumflex distributions. Gated analysis allows us to also look at cardiac function at the same time as perfusion. Hopefully this is playing okay for you guys, but we get information both technically it's not at stress, but after stress imaging and then at rest, and we can compare and look for regional wall motion abnormalities that may indicate, if we see it at stress images but not on rest images, more severe extent of ischemia.
This might be the one where you need to optimize for video.
Okay.
I mean, it's moving a little bit.
It's moving a little bit.
Yeah, it's moving.
Okay, well, I think I have some other images coming up, so let me stop and change this then, optimize. Share. Is that better?
Yeah, now it's moving, but
Now it's
then the
moving.
text went blurry. So
Right, I think
that's absolutely what is causing it.
Okay, so all right, it's going to be hard to go back and forth. This is why Zoom is, well, this is Zoom. That's surprising that it's on Zoom. WebEx usually does it worse. All right. So as I mentioned, there's a lot of prognostic indicators with nuclear scanning. I'm not going to go into all of them, but again, this kind of there's a lot of wealth of literature that shows how many vessels are involved, how the extent, how severe the perfusion defect is, as well as other things such as lung heart uptake, how big the cavity is, are all indicative of, or all have prognostic indices associated with them. I'm going to skip this. This is because it's not really about stress testing, but move on to stress echo. Similar to nuclear scanning, stress echo again gives us the imaging component, adds information about location, extent, and degree of ischemia on top of what's given by the ECG. And similar to with nuclear, we can get information on viability, as well as there's a lot of prognostic information with the addition of imaging. All right, so hopefully this is playing okay.
It is, yeah.
So,
Yes.
okay, so with stress echo, the traditional layout, well, we can do this with exercise. In this particular case, this is an exercise stress echo. And the conventional layout that we do for stress echo is rest images are displayed to the left of the stressed images. And we do it usually in 4 specific views. A parasternal view to look at, parasternal views in the long axis and short axis, and then long axis views taken from the apex of the heart. Traditionally, as I mentioned, there's 4 views. In our lab, we actually do 5 views. We add a 5th view, an apical long view. And again, this is mainly so that we can see all segments that could be affected by ischemia. If we look here, the images on the left show that all the walls seem to be thickening appropriately and squeezing. We don't see any areas that look to be thickening less than the other areas. And what we expect when the patient exercises is that we're going to get augmentation of function. So as good as it's moving here, we see on the stress images, which are again to the right of the rest images, now the walls are actually even contracting even more so. And that's what we expect. We expect when we exercise that the heart would augment and allow us to do, to give us more blood flow to allow us to continue to exercise. And so with stress, we're looking again to see if there's any regionality or wall motion abnormalities. And this is a patient who has normal augmentation of function and no regionality to wall motion abnormalities. That was an exercise with dobutamine stress, which is our pharmacologic agent that we use with stress echo. Here the convention is to put the resting images in the upper left, and then we scan the patient at low dose as well as high dose high dose dobutamine. Uh-oh, it stopped playing. Let me go back. Let's see. Don't know if it's going to let me. Oh, well, in this particular example, this was a short axis view of the heart, and peak images are shown at the bottom compared to rest images in the upper left. And again, we're looking for that augmentation of function with pharmacologic stress, and looking for regional wall motion abnormalities. Hopefully the next one plays. Uh-oh. Uh-oh. I think my computer froze or something.
We see you moving slides. I don't think there's anything. The videos aren't playing. Can you see it? Oh, here we go. We got something.
Okay. No, it's just I tried to advance and then it just advanced a lot. It went let me see if this is going to play. Okay, so this is an example of what we would see in a patient who has ischemia. So again, this is an exercise stress. We have two images at rest and then during stress to compare. And on the resting images, the wall motion is normal. But when we look at the stress images, compared to the normal study I showed you where the cavity looked like it was getting smaller and everything was, if anything, contracting more vigorously, here on the stress images, the cavity is actually a little bigger compared to on the rest images. And there are regional wall motion abnormalities. Oh, this movie stopped playing for me. That are within distribution of what we'd expect to see for LAD ischemia. Okay, let me just switch this back to okay, so similar to nuclear imaging, there are a lot of high-risk findings that can be seen on stress echo that gives information in terms of extent of disease and severity of disease, as well as has prognostic implications. I'm going to just, for time's sake, skip this slide and move on to stress MR. So stress MR, again, similar indications as with stress echo and nuclear imaging. However, at least here, we don't have treadmill equipment in our scanner room or close to a scanner. They do it at Ohio State. They do have the ability to exercise their patients and then do an MRI immediately afterwards. Here, we're limited to doing pharmacologic stress. So either with dobutamine or a vasodilator agent. More commonly here at Georgetown, we use vasodilator stress as opposed to dobutamine. And when we look at diagnostic accuracy, it's actually similar or better compared to other imaging techniques with stress testing out there. The prognosis data, it's developing, it's there, but it's still, compared to nuclear and echo stress, it's still in its infancy. But the advantage with stress MR is that you also get a lot of information on myocardial function, for which MR is considered the gold standard, as well as information about myocardial fibrosis, which is unique to MR. All right, is this playing, or do I need to switch it to the?
It's playing. It's a little slow, but it's okay.
All right. So with stress MR, with nuclear, so this is kind of like the nuclear, I consider the adenosine stress MR to be sort of equivalent to getting a nuclear scan, except that on nuclear, you're seeing a still frame shot that kind of reflects uptake already into the myocardium. With stress MRI, what we're actually looking at is we're visually watching the uptake into the myocardium. And so on rest images here, we see that there's homogeneous uptake into the muscle. On stress images, there's delayed uptake in the in certain segments of the myocardium, suggestive of ischemia in those territories. So I'm not sure if that came out, but I think, sorry, this is kind of a still frame to show regional decreased uptake in the myocardium compared on stress images. And so we can do semi-quantitative measures here to look and see at what the ischemic segment looks like compared to other segments, and calculate sort of a myocardial perfusion reserve index with stress MRI. And that has important prognostic implications as well. I did mention dobutamine stress MR. We haven't done it here at Georgetown, but at certain centers they do dobutamine stress. This is particularly important in patients who cannot get contrast, because obviously our adenosine perfusion studies require the administration of gadolinium contrast. So it does provide a non-contrast methodology to evaluate if there is underlying ischemia. And it's a technique that's similar to stress echo in terms of giving increasing doses of dobutamine and looking to see if there's any augmentation of myocardial function versus worsening of myocardial function. So in addition to these stress modalities, which I had emphasized, stress imaging is for detection of obstructive coronary artery disease. There are also non-stress imaging modalities. And I thought my CT slides were next, but it's not. So I'll go, we just go over the we'll just shift gears here and just go into other imaging modalities right now. So starting with echocardiography. So you guys have all, I'm pretty sure almost everybody out there has ordered an echocardiogram if you've taken care of any cardiac patient. As we know, this is the bread and butter of cardiac imaging. We get a lot of information on the structure of the heart. We can see the different valves, myocardium, pericardium, can look for masses and congenital lesion. We get functional information with our color Doppler to look for valvular stenosis and regurgitation. In addition, with Doppler imaging, we get information about the hemodynamics or the pressures within the heart, as well as information on how the blood is flowing throughout the heart and the valves. We already talked a little bit about stress testing in this realm as well. So when we think of echocardiography, the most standard type that we think of is transthoracic echo, where the probe is placed outside on the patient's body. There are transesophageal echo, similar to an endoscopic procedure, except instead of looking at the stomach contents, now we're looking at the cardiac structure contents. And as you can see here, because the esophagus sits right behind the heart, we actually get a nice view of the posterior structures of the heart. It's thought that transthoracic gives you better information about the anterior structures of the heart, so the right ventricle, whereas transesophageal echo gives us better information about the posterior structures of the heart, such as the left atrium. And stress echo we already talked about. So again, we use the appropriate use criteria for echocardiography to determine whether patients should be referred to or not for an echocardiogram. And there's a lot of different categories. We actually have our fellows go through the appropriate use guidelines as part of our QI project to see whether the studies that are coming through the Georgetown lab are considered appropriate or not. And for the most part, they usually are. I think, if I remember the last time we looked through these numbers, maybe about 10% of studies were ordered for inappropriate indications. And there's a wealth of information that's obtained with echocardiograms. So in general, you can almost always find an indication for an echocardiogram. In particular, patients who are in our ICU patients who have hypotension or hemodynamic instability can see it's considered to be appropriate. And particularly for assessment of valvular disease. I don't know if this can play. And so for valvular heart disease, this is probably considered, this is the first line and gold standard for assessment of underlying valvular disease. I don't know if this is playing very well, but this is a patient who has aortic stenosis related to prior radiation therapy for Hodgkin's lymphoma. And we get information, 2D information on structure, color Doppler to look for flow jets, and I don't have on here, but hemodynamic information with Doppler to look at the degree of stenosis as another secondary way to assess the hemodynamics within the heart. TEE versus TEE. Sorry, TEE versus TTE, I kind of already mentioned this. TEE provides improved visualization of the posterior structures, in particular the left atrium. We can take a look at the left atrial appendage for our patients who we might be considering cardioversions for. We also get a good look at the interatrial septum, and so in our stroke patients or in evaluating for PFOs or closures of ASDs, TEE provides information in that sense. However, compared to transthoracic echo, it's important to look at your patient and understand that TEE is a more invasive procedure and often requires sedation. And so it's an important aspect to consider in a patient who may have respiratory instability, whether or not we would we want to put them through a risk of TEE because it does require sedation. But there are, again, going back to the appropriate use criteria, there are a host of indications for TEE. Here at Georgetown, I think our most common indications have been for evaluation of endocarditis and looking closer at the valves, and in the stroke population. And on occasion, when we have a non-diagnostic transthoracic echo. And then also in our patients who have atrial fibrillation or atrial flutter, a guide to whether it's safe to do cardioversion or not in this patient. All right, so this is what I thought I was going to show earlier. This is cardiac CT. So cardiac CT has really emerged as our non-invasive modality for evaluating coronary artery disease, separate from stress testing. I came onto the scene with calcium score. So CT in general is very exquisitely sensitive to detection of calcium. With calcium scoring, we're detecting and quantifying the amount of calcium within the coronary arteries, and we use post-processing algorithms to identify and then calculate the mass of the calcium and come up with an overall calcium score. Calcium in the arteries themselves signifies that there is underlying atherosclerosis there, and it approximates the total amount of atherosclerotic plaque burden. Not all plaques are calcified, but it only shows a modest relationship with obstructive disease. There's a wealth of literature on the prognostic information that it's obtained with calcium scoring. In particular, the higher the calcium score, the worse prognosis. Higher event rates. But it's important to note that just because you have a high calcium score, that doesn't necessarily mean you have obstructive disease. And so we can see here that it signifies the presence of atherosclerosis, but it's not very good at saying, okay, just because your calcium score is really high, it means you have a 90% stenosis there. This is an example of a patient who had radiation therapy. Calcium scores over 1,000 and pretty extensive throughout the coronary arteries, and actually limited evaluation with this non-invasive technique. However, the patient underwent catheterization, and we can see that even though she has a very high calcium score, she actually has non-obstructive disease in her coronary arteries. Nothing, I mean, hardly any disease. And if it wasn't for the calcium score, probably the interventionalist would have said there's very minimal coronary artery disease. The guidelines on the approach to calcium scoring, so it's incorporated in the prevention guidelines, and in combination with using the 10-year ASCVD risk estimate, can help guide therapies as to whether or not we should consider using a statin or not. And so calcium scoring can help reclassify patients up or down when they fall in that intermediate risk group. All right, and then the addition of contrast adds more important information. It can help us with detection of non-calcified as well as calcified plaques, but more importantly, diagnosis of whether or not there's obstructive disease. This is a 65-year-old woman who presented with dyspnea. Her calcium score was 0, but when we gave her contrast, she actually had non-calcified plaque that was causing left main stenosis, as can be seen here on her contrast study. And her cath also confirmed that she had severe left main disease. So there have been many instances that show that the use of contrast can help in further prognosticating and diagnosing obstructive versus non-obstructive disease, which has important prognostic implications. All right, I think we only have 5 minutes. I'm going to just kind of skip through, and just so I can just give you a few information about MR. So MR, a lot of you have been ordering a lot of MR studies these days. As we know, We use it a lot to evaluate patients with cardiomyopathy, myocardial inflammation, myocarditis. It has a lot of indications, mainly because of its strength in tissue characterization. Most commonly in our ventricular functional assessments, so in patients who have non-diagnostic echoes or where the image quality can be limited, as long as they can fit in the scanner, we can usually get adequate image quality with a cardiac MR and calculate volumetrically ejection fraction and ventricular volumes. Probably the growth of MR came with the use of gadolinium, and showing that gadolinium actually can collect within the interstitial spaces and can be indicative of myocardial fibrosis, suggestive of infarct or other disease processes. And this was a sentinel paper performed in an animal study that showed that when we looked at histology, MRI, shown here, late enhancement, late gadolinium enhancement, actually correlated almost on an exquisite basis with the histology. We also look at where the patterns of the enhancement are to determine whether a patient has underlying ischemic versus non-ischemic disease. Ischemia usually affects the endocardium and then bridges out to the epicardium. Non-ischemic etiologies can affect almost any part. It doesn't have to follow this pattern. And so when we look at patients who have evidence of late enhancement, and we're looking at bright areas here, when we're looking to see if a patient has ischemic versus a non-ischemic etiology, those that have subendocardial enhancement tend to be of an ischemic variety, whereas those who have patchy, scattered areas that don't follow a coronary distribution most likely have a non-ischemic etiology. And so the pattern of enhancement can help predict what the underlying disease process is in terms of the different non-ischemic etiologies. However, it's still not the same as a tissue diagnosis. So it can imply that there could be a specific underlying diagnosis, but it certainly is, it's not 100% diagnostic. And then the other, kind of fallen a little bit out of favor now, but what in older literature, it was shown that the extent of enhancement, and this is for ischemic patients, so looking for viability, if you have more than 50% subendocardial enhancement, the likelihood for improvement in function is actually decreased. And so in a patient such as this one here, and I'm not sure if this is playing right, but someone who has heart failure that has severe blockages in all three arteries, and we're wondering whether or not a revascularization procedure could help improve his overall LV function. Looking at late enhancement, you can see that he does not have, he hardly has any late gadolinium enhancement, and that's limited to this apical segment down here. And so this patient underwent surgery. He's in this early postoperative period. You can see with the pair of pleural effusions in the back here. But we can already see that his function is actually improved compared to what it was when he first presented. And so that is what we want to predict before sending a patient off into surgery, is that they're actually going to manifest an improvement in their overall function. As compared to this patient who also looks like he has thin myocardium, and we're questioning whether he might improve from a revascularization procedure. And when we look at his late enhancement images, he actually has transmural enhancement affecting his myocardium, and most likely would not benefit from a revascularization procedure because he already has scar there. And so that's what the strength is in cardiac MR with viability studies and what we're trying to predict.